discussion.
USB, isn't it? So very briefly, to give a little bit of introduction on the Irish Cancer Society and our research role, we're here to ensure that Irish patients have the least risk of getting cancer, best hope of treatment if they do, and most hope of thriving afterwards, and that is our research thrust. We also obviously want patients to know about it too, and events like this are a great opportunity for us to try and ensure that where the technology allows. Okay. So we're part of the larger Irish Cancer Society. The Cancer Society invests about 15 to 20% of its budget in research because our goal is an end to cancer. And what that means in practice is we are currently funding about 85 researchers all around the country, and they're doctors, nurses, scientists, etc., all undertaking different aspects of that goal. Unfortunately, compared to international partners, even though we're the largest funder of cancer research in Ireland, we fund a fraction of the per capita investment that one would see in other places. So about 1 in 10 of the good ideas that we've actually got funding to bring forward. So to the actual cancer challenge in Ireland, and Brian touched on some of it here. This year, 40,000 new cases of cancer will be diagnosed. Next year, 42,000. Next year, the year after that, 44,000. And what that means over the 15 minutes that I will speak today, another 5 members of our community will get that dreadful news. Now that's bad, but we know from projections that by 2040, those numbers will double. And this is based on data from the National Cancer Registry of Ireland, and already we can see that their projections are short of the mark. We're already 5 years into that projection, and we're already ahead of their projection for those cancer numbers. And this is probably because their model didn't account for the increase in obesity, the fact that we're not active enough and we're sedentary, and that we've got some challenges with alcohol consumption here in Ireland. Now, the incidence of cancer is not spread equally amongst our different ages. When we're young, we're very unlikely to have a cancer diagnosis of this. But obviously, as we get older, and we know this ourselves, we see this in our communities, that much of the cancer burden is actually disproportionately in older age groups, and we're more likely to develop a cancer as we get older. On the back of that as well, over the last 175 years, longevity, the amount of time that we live has greatly increased all around the world, and Ireland is no different. So 175 years ago, half of people only lived to the age of 20. Nowadays, if you look at the graph, more than half of people live to the age of 65. Most people can really expect to live longer if they look after their health. So that has some very significant consequences in terms of cancer. Unfortunately, we have a lot of control over whether we get cancer or not, although most people perhaps don't realise this. There are a number of things whereby we can influence our likelihood of getting cancer. Smoking, most people will be familiar with. Exercise, very important. Minding and watching our weight. Keeping careful in the sun is very important. Over 10,000 skin cancers directly associated with sun exposure will be diagnosed in Ireland this year. This means that they're actually, knowing that, and we know this now from research, with that information, there are actually a number of very simple things that we can do to reduce our lifetime chance of getting cancer, and even if we do, to reduce our chance of a recurrence. And for anybody who's interested, it's called the 12 Steps to Cancer Reduction. It's a European standard, and it's available on our website if you want to follow up on that. So to put it simply, the numbers of people getting cancer in Ireland and many other countries is increasing, in part because of age and in part because of lifestyle. And we're also talking about it a bit more, so we're more aware of cancer, and people will tell when they have a cancer diagnosis now that they might have kept that in the past. In Ireland, we're on the lower end of the scale of economic investment in health in general, and cancer is no different. But we spend about 1% of our gross domestic product on cancer treatment alone, just on that one area. And cancer is many thousands of different diseases. It's really a collection of rare diseases rather than a single disease, and this is part of the treatment challenge. The problem is, as those rare cancers, as we identify through scientific means, and for example, Darren's product, as it goes forward, please God, and finds a new treatment niche, the cost of these medicines is increasing exponentially. So we have an example here of a new drug, $178,000 treatment tag per year. That's not the most expensive in the cancer space. So we're seeing a 1,000-fold increase in the cost of many of the targeted cancer medicines. Along with this, again, as some of the earlier speakers mentioned, the focus on drug development is often in oncology. Last year, the FDA approved 45 new drugs. 15 of those were specifically in oncology. So there's a lot of activity in this space, but those drugs are very expensive. So hopefully you can see from that cancer numbers will continue to rise in coming years. Treatment can be effective, and I'll show in a minute that over 50% of patients are now cured of their disease. But on an economic basis, if we look at the individual treatment costs, we will simply not treat our way out of this cancer epidemic. We simply cannot afford to just continue to treat cancer and not deal with the prevention and early detection aspects as well. Bear in mind as well that cancer is one of many similar diseases. Inflammatory diseases, arthritis, diabetes, etc. all are increasing in incidence. New medicines and new opportunities are coming along, but they are all increasing the cost. And for example, a recent example from the Times here, this is a drug, you won't be able to see it at the back, but the cost per year here is €430,000 to keep somebody alive with this particular condition. Our population is also aging, going back to my earlier point. As we get older, we're more likely to see cancer, and we can see here that by 2030, nearly 25% of the population will be retired, will be over 65. And a sizable portion of them will also be over 85, and they will have a large number of morbidities. We can just expect that. We know that as we get older. We are making a difference, and research is making a big impact, as I said, and in Ireland today, 60% of people will survive 5 years from a cancer diagnosis in general, and more than half of them will be cured. 60 years ago, when the Cancer Society was set up, no one survived a cancer diagnosis for any great length of time. And that's the advent of research, new medicines, etc. But it has challenges that come with it as well. It means that at the moment we have 170,000 cancer survivors in Ireland, people who've been through a cancer journey. Many of them are cured, many of them are also living with cancer, and often we don't know who is who. That's the size almost of the population of Cork. And they have specific needs and challenges in terms of their treatment as well. So people think, I get cured of cancer and isn't that nice and everything gets back to normal. Unfortunately, this is some research from Macmillan. We've done our own research in this area as well. You can't read this at the back, but what it basically says is 500,000, or 1 in 4, of cancer patients in the UK develops a disability associated with their treatment or with the illness that they've got in the form of cancer that they have. They can develop life-limiting fatigue, which can impact relationships, which can impact their ability to work, impact to have any sense of normality. Most cancer patients will tell you that the fatigue is the single biggest difficulty that they face. There can be sexual issues, mental health issues, chronic pain, and various other medical issues as well. And these are all very high prevalence. We did some research as well to show not alone that, but there are big economic consequences. The average person is nearly €900 short when they have to pay for all the extra medicines, the extra heat, travel, etc. per month associated with their cancer treatment, not including their loss of earnings and salary when they can't work. So around a quarter of cancer survivors are disabled in some way. There's a lot of ignorance in the workplace around how to manage people that have cancer, how to bring them forward, how to help them, how to support them, etc. They are living longer because we're getting very good at treatment, but economically there's a lot of personal cost to them. The treatment cost to them and to society are mounting up, and their ability to make economic contribution in terms of working and taxation, etc. is severely compromised. So the cost of sustaining survivors is greatly increasing. So more of us are going to get sick, more of us will live longer, but we'll need treatment for the various different diseases, including cancer, that we're going to get. The cost of that treatment is spiralling and ever increasing. The impact is far from benign. So in other words, treatment itself has sequelae and consequences which have hard economic implications, because we're less able to work, etc. That burden is also larger among people who can least afford. The cancer rate is much higher among people from poorer backgrounds than it is from people from the higher socioeconomic groups. So what do we do about this? Simple solution is we keep going the way we're going and we bury our head in the sand. And this is in part what many different people are sort of advocating when we look at some of the general election coverage we've seen lately. The second solution is what I might call the flooding analogy. I volunteer at the Civil Defence and I've been out in some of the floods lately. And what we do in flooding is we buy more pumps and we put more water out, etc. But that's throwing bad money after an eventuality. we're not really dealing with the root cause of the flooding in the first place, which is a much more appropriate investment. But when people have immediate need, it's very difficult to make that transition. So what we need is some sort of bioeconomic strategy to bring control of these challenges. We need to work together, and the payers, the people who are actually paying the money, patients, the state, etc., the various health insurance, etc., companies, the people who are providing the resources, healthcare professionals and the state, and also the people who are receiving the money, the diagnostic and pharmaceutical companies who are developing new treatments and implementing them. How do we do this? Some of you, I'm not sure if you can see this at the back, you might have seen the recent Matt Damon film, and partway through, after he's found himself in a very difficult situation, he says, I'm going to have to science the shit out of this. So I've taken that on board. I am a Matt Damon lookalike, obviously. So we're going to have to research the shit out of this. We really are, because our only way forward is to do it intelligently. And it's about finding new ways through research and acting on the information and intelligence that research is giving us. It's about, as we say, what's called action research. And we're focused in 4 key areas: prevention, early detection, treatment, and post-treatment and end-of-life care. Because each of those areas, there's research to show how we can make improvements and how those improvements can be economically viable. So in terms of prevention, just to pick on one area, you'll all be very comfortable with smoking. Smoking kills 5,500 people in Ireland each year, not to mention the tens of thousands of people who suffer significant disabilities associated with smoking, who, for example, if they've got diabetes, are at very high risk of limb loss and amputation and other medical complications. An old, nearly 7 years old now, it costs the healthcare industry in Ireland 500 million alone. And the success of cessation and ending smoking is actually very, very poor. About 1 in 20 people who try to quit smoking on their own will ultimately be successful. Unfortunately, there's a disproportionate burden, and our poorer community have a much higher incidence of smoking, and they're a very difficult community to try and engage with cessation and explain the reality and the economic reality for themselves and understand the health message. This is just illustrated on the pie chart here. So with that research, we developed an evidence-based program called We Can Quit, specifically focused on women from poorer communities, and that has a 46% success rate. If we round things up, that means that we're 10 times as good at getting those people to quit as if they've just done it on their own. But it takes investment and it takes knowledge and know-how to make the proper investment in those people. Early detection is very important. Bowel cancer will kill 1,000 people this year in Ireland, maybe a little bit more. We have a great test for it, an FIT test, which is available to everybody once they hit their 60th birthday. The state automatically writes to you and invites you for this test. But only 1/3 of eligible men actually take the test up. Many men in particular are very fatalistic about this. And this means that those men will go on to develop, some of those men will go on to develop a cancer which could have been picked up and treated much earlier. Unfortunately, this slide won't project well at the back, but this is research from Cancer Research UK which shows that if colon cancer, bowel cancer, is caught early, 9 in 10 people will be cured. If it's left and it ends up in stage 4, less than 1 in 10 will be alive at 5 years. So you can see the economic and societal impact of early detection.